Okay, so now these are those patients who actually received early fibrinolytic therapy or did not receive anything at all. So coronary angiography in patients who initially were managed with the fibrinolytic therapy or who did not receive reperfusion, cardiac catheterization and coronary angiography with intent to perform the revascularization should be performed after a STEMI in patient. Which patients? These patients. And these all are patients. It is class 1 to go the cardiac catheterization in following patients: the cardiogenic shock or acute heart failure that develops the initial presentation, intermediate or high risk findings on the pre-discharge non-invasive ischemia testing. It means you have sent your patient for the non-ischemic testing like thallium, MPS or stress echocardiography or anything on on non-invasive. If you have gotten the high risk finding, then it is class 1 to go for the angiogram. Myocardial ischemia that is spontaneous or provoked by the minimal exertion. If it means that before discharging your patient, if you have assessed the functional class of your patient and you assess that you're on the minimal exertion, your patient is developing symptoms, so it is class 1 to get done the coronary angiography done before before sending him home. Coronary angiography in patients who initially were managed with the fibrinolytic therapy excuse me, who did not receive reperfusion. Coronary angiography with intent to perform the revascularization is reasonable for patients with the evidence of failed reperfusion or reocclusion after a fibrinolytic therapy. Angiography can be performed as soon as logistically feasible. So it is class 2A that for to intend to perform revascularization in the reasonable patient or in those patients who have the failed reperfusion done, then it is, if the logistically feasible, you need to done as soon as possible. Coronary angiography is reasonable before hospital discharge in the stable patient with the STEMI after successful fibrinolytic therapy. It is class 2A. In successful therapy, if your patient is even asymptomatic, it is better to get done what? Angiography. Angiography can be performed as soon as logistically feasible, ideally within 24 hours. Okay. Upper one was what? The failed reperfusion, but it is telling us about the successful fibrinolytic therapy, that it is better to get done all these things in within 24 hours, because after 24 hours, if there is any occlusion, that would be calcified or probably there would be more changes which may become permanent. So these are the same things which we discussed. Delayed invasive management, PCI of an infarct artery in patient who initially were managed with the fibrinolysis or who did not receive the reperfusion therapy. Same thing. Okay, delayed invasive on those patients who actually got the fibrinolysis or did not receive at all. So PCI of the non-infarct in the patient of an PCI of an infarct artery in patient who initially were managed with fibrinolysis or did not receive reperfusion therapy. Those were the patients who actually received the therapy. Okay, the PCI of an anatomically significant stenosis in infarct artery should be performed in patient with suitable anatomy and any of the following: cardiogenic shock or acute failure, it is class 1 to go for the PCI, and immediate, intermediate or high risk finding of the pre-discharge non-invasive ischemia testing, it is again class 1, and again myocardial ischemia, that is spontaneous or provoked. These are the same things which we discussed, but the only thing is that these patients are going for the PCI if their infarct artery who were initially not managed with the fibrinolysis and did not receive anything. Now initially you are going for the angiograms, coronary angiograms, now you are going for the PCI. So the things are same. Obviously, if you are going for the angiogram, it means that you have intentions of doing what? Reperfusion, either with the PCI or CABG. PCI of an infarct artery in patient who initially were managed with the fibrinolysis or who did not receive reperfusion therapy. So, okay, so delayed PCI is reasonable in patient with a STEMI and evidence of the failed reperfusion or reocclusion after fibrinolytic therapy. So PCI can be done. It is class 2A. PCI of an infarct artery in patient who initially were managed with the fibrinolysis or did not receive same. This is the same scenario, but here we have a patient of like delayed PCI of a significant stenosis in patent infarct artery is reasonable. If your artery is patent, like this artery is open, then it is class 2A to do the delayed PCI with the STEMI after fibrinolytic therapy. But PCI can be performed as soon as logistically feasible, and ideally it should be done within 24 hours, but should not be performed within first to 2 to 3 hours. As I told you that in facilitated PCI, it is better to shift your patient after 2 to 3 hours and do the PCI or within 24 hours, and do the PCI before 24 hours and after 2 to 3 hours. Delayed PCI of significant stenosis in a patient sorry, delayed PCI of a significant stenosis in patient in a patent infarct artery greater than 24 hours. If you have elapsed the time of 24 hours after fibrinolysis, then now it has become 2B. So before 24 hours, it is class, before 24 hours, if you are doing the facilitated PCI, it is class 2A. And if you are doing facilitated PCI after 24 hours, it is class 2B. Delayed PCI of totally occluded artery, like you have done nothing, like you did not open the artery, or you have seen on the angiography that your artery is totally occluded and time has been elapsed more than 24 hours through the STEMI, then now to open that artery is class 3. Before opening it, you need to go for what? Non-invasive investigations. These are the same things which we discussed here. PCI of non-infarct artery before hospital discharge. I told you that initial trials, Culprit trial told that actually if you are going for PCI of the non-infarct artery, it has no benefit, or either it would increase the mortality. But now newer trials from European from in Europe, from the European guidelines and the ACC and AHA updates, it showed that actually it has benefit if you can go for PCI of the non-infarct artery. So this is again PCI is indicated in the non-infarct artery at the time of the separate from the primary PCI. They, now the trials complete, and I think Prague trials, they are actually emphasizing us to do the PCI on the same hospital administration. But initially in 2012, it was indicated that to do these things in separate index hospitalization. PCI is reasonable in the non-infarct artery at a time separate from the primary PCI in patient with the intermediate or high risk findings on non-invasive testing. So these are the actual indication on which it is class 1 to do on a separate admissions. But if you're going for non-invasive investigation and you are getting intermediate or high risk finding, then it is class 2A to go for the PCI. So adjunctive antithrombotic therapy to support the delayed PCI after fibrinolytic therapy, or antiplatelet therapy to support the PCI. So after PCI, as you know that the aspirin should be continued indefinitely. Clopi, now you have done, after fibrinolysis you have done the PCI. So again, all the options have been open for you. After fibrinolysis, you had only one option, that was what? Clopidogrel. But now you have done the PCI over fibrinolysis. Now all the options have open for the P2Y12 inhibitor for you in the P2Y12 inhibitors. These are again the same, the clopidogrel, the Presu, and the Tika. But obviously in the loading dose, you have the clopidogrel that would be given 60 mg, as Armida told that 600 mg of the clopidogrel actually decreases what? Perioperative MI. So it is actually what? It is class 1. These are the class 1. So after PCI, it is reasonable to use the 81, the maintenance dose of the aspirin, as I told you, and Presu, as I told you that you cannot use the Presu before angiography, so you can use here now Presu in the 60 mg loading dose, and after that you have to continue 10 mg as a maintenance dose. So Presu should not be given in which patients? In PIA patients, or with a stroke, any stroke. Anticoagulant therapy to support the PCI after fibrinolytic therapy. So for the patient with STEMI undergoing PCI after receiving the fibrinolytic with the IV infection, additional boluses of the IV infection should be administered at the knees to support the procedure. Obviously, now you are going for the PCI after fibrinolysis, then you can give the boluses of the infection heparin, as we discussed earlier, and whether taking into account whether GP2B3 receptor antagonists have been administered. Because if you have given the 2B3 inhibitor, then obviously you need to decrease the dose of the unfractioned heparin, as we discussed earlier. For patient with the STEMI undergoing the PCI after receiving fibrinolytic therapy with inox, if the last subcutaneous dose was administered within the prior 8 hours, no additional enoxaparin should be given if the last subcutaneous dose was administered between 8 to 12 hours earlier. Okay, so enoxaparin 0.3 should be given. Now what it tells that if the last subcutaneous dose was administered within prior 8 hours. If you have given the prior 8 hours enoxaparin to your patient, then no additional enoxaparin should be given to the patient for supporting the PCI. But if the last subcutaneous dose were administered between 8 to 12 hours, then you will give only 0.3 mg per kg dose to your patient. And if your patient is presenting more than 12 hours, then obviously you will give the full dose. Fundoprinox should not be used, as I told you that in the PCI, fundoprinox should not be used as a sole agent to support the PCI because it is class 3. These are the same things. CABG in patient with STEMI. So CABG in patient with STEMI, urgent CABG is indicated in patient with STEMI and coronary anatomy not amenable to the PCI who have ongoing or recurrent ischemia, cardiogenic shock, severe symptoms. Like if your patient has the indication of reperfusion but it is not amenable to the angiography or angioplasty, then it is better to go for the urgent CABG. It is class 1. CABG is recommended in patient with STEMI at the time of operative repair of mechanical defects. If you are going for any repair of mechanical defects like MVR, AVR or anything, then it is better to done the angiography and do the CABG if it is indicated. So CABG in patient with STEMI, the use of the mechanical circulatory support is reasonable, like IABP in patient with STEMI who are hemodynamically unstable. If your patient is unstable, so it is class 2A. Shock trial told us that if your patient is hemodynamically unstable or in the cardiogenic shock or going into the cardiogenic shock, then it's better to give the mechanical circulatory support before going for CABG. So emergency CABG within 6 hours. What is the emergency CABG? Actually, emergency CABG is within 6 hours of symptoms onset may be considered in patient with STEMI who do not have a cardiogenic shock and are not candidate for the PCI or fibrinolytic therapy. So these are the things for emergency CABG who have a symptoms. May be considered patient who with the STEMI and do not have a cardiogenic shock, because with the cardiogenic shock you cannot do the CABG. Okay. Timing of urgent CABG in patient with STEMI in the relation to use of the antiplatelet agents. Aspirin should not be withheld before urgent CABG. Got it. Timing of the urgent CABG in patient with STEMI in relation to use of the antiplatelet. So aspirin should not be withheld. These all things we discussed in our lectures that aspirin should not be withheld. You can safely continue this aspirin with CABG. Clopi and Tica should be discontinued at least 24 hours before urgent on pump CABG. But if the CABG is elective, then you need to hold the Clopi and Tica before 5 days. Okay, 5 days before you need to hold Clopi and Tica before your CABG. Short acting IV GP2B3 receptor antagonist, you can continue it safely until the 2 to 4 hours, and you need to discontinue it at least 2 to 4 hours before urgent CABG if you have given the epitephabide and tirofiban. But if you have given epeximab, then approximately you need to hold for 12 hours. And all these things we have discussed this in our lectures. Urgent off pump CABG within 24 hours of the Clopi or ticagrelol administration might be considered, especially if the benefits of the prompt revascularization outweigh the risk of what? Bleeding. Then the urgent off pump CABG can be done within 24 hours of the clopidogrel or ticagrelol administration. You can do it, but it is class 2B. But holding all these things is class 1. Okay. So if you are doing it, so it is class 2B. It is actually risk versus benefit. Urgent CABG within 5 days of Clopi or Tica administration or within the 7 days of the procedural administration might be considered, especially if the benefit of the prompt revascularization outweighs. Again, this is the risk versus benefit. If you have not held your like Tica, Presu or any P2Y12 inhibitor and before 5 days, so if you are going for the urgent CABG, it is class 2B. But it would be like risk versus benefit situation. Okay, got it? So what it told us that it should be discontinued at least 24 hours before urgent. Okay, so now here is urgent within 5 days of Clopid. So it is actually doing what? It is urgent CABG within 5 days of clopidogrel or ticagrelol administration or within 7 days of procedural administration might be considered, especially if the benefits of the prompt revascularization. What is timing of the urgent CABG? I'm sure that you have getting the things properly. You are getting the things properly. So routine medical therapies. Obviously, you know that the beta blockers, you need to put your beta patients on the beta blocker within 24 hours until there is any contraindication. And the contraindications, you know that the PR interval more than 240 milliseconds, second or third degree heavy block, active reactive airway disease, or the asthma. The beta blocker should be continued during and after hospitalization, after with STEMI, and no contraindication to their use. Okay, so it is class 1 to continue the beta blockers. If the patient has one thing more I want to tell you here, that if your patient has been taken beta blockers on normal EF, then it is reasonable to hold the beta blockers after 3 years if your patient has not faced any like acute ischemic event in last 3 years. So patient with the initial contraindication to use of the beta blockers in the first 24 hours after STEMI should be re-evaluated to determine their subsequent eligibility. If you analyze your patient, like if you analyze your patient and you see that your patient is not indicated yet for the beta blockers, then again and again in every 24 hours you will re-evaluate your patient for putting him or her on beta blockers. It is reasonable to administer IV beta blockers at the time of presentation to the patient with STEMI and no contraindication to their use who are hypertensive or have ongoing ischemia. If your patient has presented with a hypertensive emergency, okay, in hypertensive emergency, so it is reasonable to give IV beta blockers until there is no contraindication. RAS system, sorry. So ACE inhibitor should be given in first 24 hours. These two drugs should be given in first 24 hours to all patients with STEMI, and especially with the anterior location, with to all patients with STEMI with anterior location, heart failure or EF less than 40 unless contraindicated. Got it? So it is class 1 to those. And the additional things on this, which HOPE trial actually told us, and the HOPE trial was done on the Remipase, and it actually told us that if your patient has EF less than 40% and diabetic or hypertensive, so or he or she has a stable CKD, so it is better to put your patients on ACE inhibitors if he or she had MI. So it is class 1. And ARB should be given, again this is ARB or ACE, both are class 1 in STEMI in these conditions which I have told you earlier. So an aldosterone antagonist should be given to the patient with STEMI, no contraindication, who are already receiving an ACE and BEAT. So aldosterone antagonist is actually the third drug to add on in the adjunctive therapy. It is not the first or the second drug. This is the most important part of the guidelines, that this is the third drug to add on. Okay, this is not the first or the second drug actually. So it is a malpractice to aid aldosterone before ACE inhibitor or beta blockers. Okay, and in which patients you actually use the aldosterone, these are again the same patients of EF less than 40% or either symptomatic heart failure or diabetes mellitus. ACE inhibitors again are reasonable for all patients with STEMI and no contraindication. If your patient has nothing like EF, diabetes and symptomatic heart failure, so it is class 2A to give the ACE inhibitors. Lipid management, the high intensity statin should be initiated or continued in all patients with STEMI and no contraindication to the use. It is class 1. It is reasonable to obtain a FLP, fasting lipid profile, within 24 hours, class 2A. Complications, cardiogenic shock, treatment of cardiogenic shock, again the same emergency. These are okay. Actually, these are the guidelines after the STEMI for cardiogenic shock. Okay, like what you will do if your patient had cardiogenic shock after STEMI. Got it? Actually, these are the guidelines. These are the guidelines for what? Complications of complications after ST elevation MI or complication of the ST elevation MI. So that first and the most common complication of STEMI is treatment of is cardiogenic shock. So what you will do in the cardiogenic shock, emergency revasc with either PCI or the CABG is recommended in suitable patient with the cardiogenic shock due to pump failure. After STEMI, irrespective of time delay from MI onset, obviously you need to give the emergency revasc. It's a class 1. In the absence of contraindication, fibrinolytic therapy should be administered. You can give the fibrinolytic therapy if you have no any options of the PCI. The use of the intra-aortic balloon counterpulsation, it is class 2A if the patient is in the cardiogenic shock and he or she needs it. But the usage of the routine usage of the IABP or in STEMI patient is class 2, is class 3. Alternative LV assist device for circulatory support may be considered in patient with the refractory cardiogenic shock. It is class 2B. The alternative like elevate, usage of elevate in the cardiac shock is class 2B, but nowadays it is becoming class 2A. So electrical complication in hospital during the hospital phase of STEMI, like what would be the electrical complications such as ventricular sustained ventricular tachycardias or VF. So ICD therapy is indicated before discharge in patient who developed the sustained VT and VF more than 48 hours after STEMI, because if your patient has developed the symptoms more than 40 after 48 hours, probably these symptoms or these VT and VF because of the scar. But it is if your patient had VT and VF before 48 hours of your presentation, then it means that this is because of ischemia, and then it is better to go for the reperfusion therapy in those patients. So Brady, AV, and the IV conduction defects, pacing in temporary pacing is indicated for the symptomatic Brady arrhythmias unresponsive to medical therapy. In any symptomatic Brady arrhythmia, even in the first degree AV block or sinus Brady, you need to give the temporary pacing. It is class 1. Pericarditis. Management of the pericarditis, aspirin is recommended, as you know that it is class 1. Administration of the acetaminophen, colchicine, narcotic analgesic, these all are the class 2B. These all are the classes class 2B if the aspirin even the higher doses is not effective. Initially you need to put the patient on the high doses of the aspirin, but if your patient is unresponsive to the high dose of aspirin, then you will give acetaminophen, colchicine, all these things, but again these things are class 2B. Glucocorticoids and NSAIDs are potentially harmful in the STEMI patients because it actually causes what? It causes the perforation and ventricular septal ruptures, and so that's why steroids and the non-steroid NSAIDs, these are contraindicated in STEMI patients. Thromboembolic and the bleeding complication, anticoagulation, the following recommendation is again who receive the intracoronary stents for STEMI. Among individuals with the STEMI who do not receive an intracoronary stent, the duration of the DAPT beyond 14 days has not been studied. Okay, so those patients who actually have done with the fibrinolysis, so you can only give DAPT for 14 days. Beyond 14 days, it has not been studied well. So it is class 1 to give the DAPT for the 14 days. And but if you have done the PCI on this patient, obviously then you need to give the DAPT of 1 year. Anticoagulant therapy with the vitamin K antagonist should be provided to patients with the STEMI with AFib according to the Chadwick. Okay, or equal to the equal to 2 or mechanical heart valves, venous thromboembolism, or hypercoagulation disorders. So again, these are those conditions in which you will do the anticoagulation irrespective of atrial fibrillation or not. So in those conditions, you will not calculate the Chadwick. The duration of the triple anti-therapy with the vitamin K antagonist, aspirin, and the P2Y12 receptor inhibitor should be minimized to extent possible to limit the risk of what? Bleeding. So the thing is that now the so many things have been updated in this regard, that now you can use the DOAX, like you can with the DAPT if your patient has atrial fibrillation and non-valvular AFib. So in those patients you can put your patients on the rivaroxaban with like the 15 mg OD of rivaroxaban with DAPT. Okay, with DAPT for first 3 months, and then after that you will continue the clopidogrel and what your rivaroxaban for 1 year, and then after 1 year you will switch your patients on the aspirin and the rivaroxaban. So these are actually trials, and the trial who actually supported the usage of the rivaroxaban in the atrial fibrillation in STEMI patients after PCI with DAPT is what? Pioneer, AFib, PCI. Got it? So there are so many trials over dabigatran, okay, that is a Redual, and apexaban, and on your Aristotle is for, I think, apexaban. So there's all the now so many things have been updated on this regard. So these are the older guidelines. So please look at these things. Anticoagulation therapy with the vitamin K antagonist is reasonable for patient with the STEMI and the asymptomatic LV mural thrombus. So anticoagulation, obviously you need to for the mural thrombus there is not indicated that you cannot give DOX or NOX for mural thrombus. The only choice for the anticoagulation for mural thrombus is vitamin K antagonist. That is the warfarin. Anticoagulation therapy may be considered for patient with the STEMI and the anterior apical echinasis for the disc or dyskinesis. Got it? So anticoagulation therapy may be considered for patient with STEMI if there, but Champs and Cars actually told us that there is no benefit, but it actually increases what? It actually increases the bleeding risk for those patients if you are putting them just because of the apical akinesis or dyskinesis. So it is better not to give the anticoagulation those patients because of the dyskinesia and the aneurysms. Targeting vitamin K antagonist therapy to INR, obviously you need to put the INR in between 2 to 2.5 with DAPT. The risk assessment after STEMI, so use of the non-invasive testing is a better option to re-stratify or to risk stratify your patients before discharge. Non-invasive testing for the ischemia should be performed before discharge to assess the presence and extent of inducible ischemia in patients with STEMI who have not had coronary angiography and do not have the high-risk clinical features for which the coronary angiography would be warranted. So non-invasive testing is obviously performed before hospital discharge. Obviously you will look for other signs, and then if your patient if it is indicated, then you will go for the angiography. Non-invasive testing for the ischemia might be considered before discharge to evaluate the functional significance of a non-infarct artery. If your patient has a completely occlusion in the non-infarct artery, if your patient has anterior wall MI and there is an occlusion of the right coronary artery, then obviously you will go for the non-invasive testing to risk stratify or to see the functional significance of non-infarct artery. Non-invasive testing for the ischemia, it is class 2B. Non-invasive testing for the ischemia might be considered before discharge to guide the post-discharge exercise prescription, that how much exercise should be prescribed to the patient if they're to actually check the functional capability of your patient after myocardial infarction. Assessment of the LV function, okay, obviously LVF should be assessed in all patients after STEMI. It's class 1. Assessment of the risk for sudden cardiac death. Patient with the initially reduced LVF who are possible candidate for the ICD therapy should undergo for the re-evaluation of the LVS 40 or the more days of the discharge. We know that if you are suspecting that the increased risk of sudden cardiac death in those patients who actually presented with the anterior wall MI or the low EF after STEMI, then you need to wait at least for 90 days in those patients who have gotten their reperfusion therapy either with the PCI or thrombolytics, and on those patients who haven't gotten anything. So in those patients, you can wait only for 40 days. Post-hospitalization plan of care. This is actually important thing which we do not practice, and it has a lot of mortality benefit in our patients. Post-hospital system of the care designed to the prevent hospital redemptions should be used to facilitate the transition to the effective coordinated outpatient care for all patients with STEMI. Exercise-based cardiac rehab and the secondary prevention program, these all are the class 1 indications. Okay. A clear, detailed, evidence-based plan of the care that promotes the medication adherence. It is class 1. Timely follow-up. It is class 1. Appropriate dietary and the physical activities to tell patients about it. It is class 1. And compliance with the intervention for the secondary prevention. It is class 1. Encouragement and device to stop smoking and avoid secondhand smoke should be provided to patient. It is class 1. Okay, so you need to tell your patients about it. So we have done here the post-hospitalization plan of care, and I hope that you have learned a lot about the guidelines of the ST elevation MI, and then inshallah very soon we will start the unstable angina and non-ST elevation of MI. Allah Hafiz. Take care.